very hot summer day. And thank you, Novo. It has always been a privilege to be working with you. I've been with you, I've traveled with you, and sometimes I get surprised how can you concentrate so many good people at one particular place. Starting with the presentation, it's about obesity. It's about the treatments that we have heard of. It's about a new drug that has been introduced a month ago in Pakistan. And to be very specific, it's about the selection of patients. In which patients are we going to select Wegovy, and in which patients we are going to use some other drugs as well. It's not, it's not a pharma-based presentation or so. So where we'll have indications for Ozempic, where we'll have indications for Semaglutide or Wegovy, we'll be open to discuss. And if there are any questions, any myths about these drugs, we'll have a question and answer session later on. Speaking about obesity, for decades, obesity has been a battle between willpower and biology. हम कर लेंगे, जिस दिन हमने इरादा किया जिम करने का, हम उस वक्त कर लेंगे, हम कर सकते हैं. And as time passes and we end up with end organ damage, the adverse cardiovascular events, the strokes and the hypertensions and the osteoarthritises and whatever, वहाँ पे जाके हम realize करते हैं कि नहीं, ये इतना आसान नहीं था. It was a complete disease with end organ complications. And when those complications set in, that is the time where we realize कि उस वक्त पे अगर proper treatment or proper therapy करते, तो शायद we wouldn't have ended up with these end organ damage and these complications that are related to obesity, and those that are related to diabetes as well. उस stage पे आके willpower भी नहीं रहती और the damage has already been done. So the entire focus of this presentation would be to choose the appropriate drugs at the appropriate time and in the appropriate patients. Obesity is my problem. Obesity is our problem. Obesity is a problem that we face in the third world countries mostly. And the data shows that the global prevalence of obesity has tripled in the last 4 decades. And the numbers become even more staggering when we collect the data of the third world countries, India, Pakistan, Bangladesh. This number has multiplied more rapidly as compared to the West. 1 billion people at present, and by the year 2035, it is expected to increase to up to 4 billion. It is expected that the data might increase, the population might increase to up to 1/4 and 1/2. It might be somewhere between 1/4 and 1/2 by the year 2035. So we could safely say that approximately half of the world's population by the year 2035 is expected to be obese. And that is a big figure. We all know what health is. Being healthy is a privilege, is an achievement these days. Obesity is something that destroys it. A very important slide. Obesity is classified differently. According to American Diabetes Association, according to WHO, the Asian population, there is a very strict, stringent criteria in the Asian population regarding diabetes. What they tell us is that anyone with a BMI of greater than 25 in India, Pakistan, Bangladesh, Maldives, or countries like this are obese. Why would they say this? Because we have a tendency to develop atherosclerotic cardiovascular complications at a lower BMI as compared to the rest of the world. So they've classified us differently as compared to the others. In the rest of the world, 18.5 to less than 25 is the normal BMI. For us, it's less than 23. And the same goes with pre-obesity as well. So this classification puts us at a further risk, and also, validates that early treatment should be done in Asian population as compared to the rest of the world. Elaborating this slide further, it's the waist circumference that is 88 centimeters for men, for women, and 102 centimeters in men. Now, consider two different people, one with a BMI of 25, which is relatively better, but with a greater waist circumference, has to end up with more complications as compared to someone who has a BMI of 30, but a lesser waist circumference. And this is what we regard as central obesity and adipose-related obesity. That is where it becomes more dangerous. So even this classification is sometimes in a myth that whether BMI is more dangerous or it's the central obesity or the waist circumference that is more dangerous. Now, this is a wonderful slide. It shows the dots, which are the minor complications of diabetes and obesity. Then the dots multiply to tell us that these complications are more in number, more in prevalence, and more dangerous. These are readable complications, GERD and others. Again, complications that are more in number. And last but not least, when obesity complicates type 2 diabetes, hypertension, gestational diabetes, these are the complications that we experience so many times. Obesity is associated with multiple complications. This is a repetition of the last slide. An important slide to discuss is BMI. BMI related treatment. We all know BMIs of greater than 35 to 40 will need surgery. BMIs of 30 to 35 can go for pharmacological management. And those with comorbs, that is the point. With comorbidities, if an obese patient has diabetes, if an obese patient has MASLD, that is where at an earlier BMI, surgeries and bariatric surgeries have their role in them. Bariatric surgeries are recommended at an earlier BMI for patients who have complications with obesity, and those without complications may just prolong their pharmacological therapy. Now, which drugs should we use? That was our point that I was making at the initial part of the presentation. Sometimes we come across patients who do not have obesity-related complications. For them, we have a wide variety of drugs. We can use tirzepatide, we can use semaglutide, we can use phentermine, we can use orlistat. These are all beneficial for weight loss. But when it comes to complications of obesity, then we'll have to be very specific about the drugs. For instance, one issue that has been plaguing us for a very long period of time is MASLD, MASH, liver-related disorders that are present with obesity. In all such patients, semaglutide overtakes tirzepatide as the number one drug. Similarly, if there is a hypertensive heart failure with preserved ejection fraction, semaglutide is the drug to give. Tirzepatide is only a class B indication. Patients with osteoarthritis, patients with atherosclerotic cardiovascular disease, all patients will have semaglutide as class A indication, and only one obesity-related complication, OSA, obstructive sleep apnea, will have tirzepatide as class A and semaglutide as class B. Otherwise, in pre-diabetes and type 2 diabetes, we have both the same. Both are class A recommendations. So this helps us identify patients in whom we can use semaglutide, in whom we can use orlistat, in whom we can use phentermine or semaglutide or Wegovy in all such patients. GLP-1, as we all know, is amino acid peptide. It is secreted in response to meal ingestion, and it acts on the pancreas, on the kidneys, on the brain, on the heart and the lungs. The tissue effects will be increased insulin secretion and decreased glucagon secretion. This is the main effect from the pancreas. The other effects include decreased gluconeogenesis from the liver. Gastric emptying is delayed, so there is early satiety, there is reduction in appetite, and that is basically the mechanism of action at which Wegovy or semaglutide would work. So Wegovy suppresses from two methods, two regulators, homeostatic regulation and hedonic regulation. Homeostatic regulation would increase satiety, whereas hedonic regulation will reduce the food craving for those food products that are very notorious. So it works in both ways. The cardiometabolic effects, there is a marked reduction in cardiovascular events, and that is something that we all know. But an important slide is the step-up slide. We initiate Wegovy from a dose of 0.25 milligrams per week for the first month. Then we step up to 0.5 milligrams per week for the second month. Then it's 1 milligram. When it was Ozempic, it was only 1 milligram, but with Wegovy, we have higher doses, 1.7 and 2.4 milligram as well. Now, the current FDA-approved dosage is 7.2 milligrams, which is at least 3 times higher than what we have. But in Pakistan, that is not currently available. So we have Wegovy at 2.4 milligrams, which is a very important drug. Why is stepping it up necessary? Why wouldn't we, start a patient who presents to us at a weight of 165 kilograms with 2.4 milligrams of Semaglutide? The reason is that when we step it up, the gastrointestinal complications that develop with Wegovy will have a very reduced role in them. Sometimes we start at a higher dose, and the GI side effects, become a reason for ending the treatment or for discontinuation of the drug. I remember one patient who presented to me from Gujranwala. He has had a very big meal, और उसके ज़हन में ये था कि कल से तो मैंने Wegovy स्टार्ट कर देनी है, तो मैं आज जितना खा सकता हूँ खा लूँ. और उसने सुबह एक बड़ा हैवी नाश्ता किया, वो आप अंदाज़ा लगा सकते हैं. दोपहर का खाना खाया, एंड एट डिनर टाइम उसने जो है Wegovy की पहली डोज लगाई, सेटिस्फाइंग हिमसेल्फ कि जी अब मैंने कुछ महीनों के लिए खाना खा लिया और अब जो है मैं Wegovy लगा लेता हूँ. और ही डिसकंटिन्यूड द ड्रग द वेरी नेक्स्ट डे, क्योंकि उसको इतनी वॉमिटिंग हुई सारी रात में और इतना नॉजिया रहा कि ही फेल्ट कि दिस इज नॉट द ड्रग फॉर हिम. तो दिस इज वन एडवाइस दैट वी गिव पीपल कि व्हेन इट इज द स्टार्ट ऑफ Wegovy, इट्स नॉट द एंड ऑफ द वर्ल्ड, यू कैन डिसकंटिन्यू इट एट एनी पॉइंट इन टाइम. तो आपका जो खाना पीना है उस दिन और उस हफ्ता वो मैटर करता है. यू मेड अप योर माइंड फॉर वेट लॉस, तो फिर आपका जो खाना पीना है वो आपने रिस्ट्रिक्ट करना शुरू कर देना है. एंड ऑब्वियसली विद टाइम, with early satiety and with reduced appetite, आप इतना ज़्यादा खा ही नहीं सकेंगे. मैं अपने बहुत कम लोगों को Wegovy पे या Semaglutide पे डाइट एडवाइस करता हूँ. मैं उसे कहता हूँ आप जो मर्जी खाएं, एंड दैट इज व्हाट मेक्स देम वेरी हैप्पी. क्योंकि मुझे अंदर से पता होता है कि जब इनकी एपिटाइट ही नहीं होगी और इनका दिल ही नहीं करेगा खाने को, तो आई कैन बिकम अ वेरी फेमस एंड अ वेरी गुड डॉक्टर ना, कि मैं इनको खाने पीने से मना ही नहीं कर रहा. तो फिर सिंस सप्रेशन ऑलरेडी हो जानी है, तो आई डोंट थिंक सो डाइटरी रेगुलेशन जो है उसके अंदर इतनी ज्यादा रिक्वायर्ड. द स्टेप प्रोग्राम, वी जस्ट वर डिस्कसिंग द स्टेप प्रोग्राम. Wegovy के स्टेज 3A 3B क्लिनिकल डेवलपमेंट ट्रायल्स हैं बहुत सारे अगेंस्ट मेनी ड्रग्स. दिस इंक्लूड्स पीपल विद BMI of greater than 30 or a BMI of greater than 27 with at least one complication, and this is where Wegovy leads the rest. You can name a drug for weight loss, और उन सब के इतने ज़्यादा ट्रायल्स नहीं हैं. अभी हम अगली स्लाइड में डिस्कस करेंगे ट्रायल्स के बारे में. बट वी हैव अप्रॉक्सिमेटली 18 ट्रायल्स which are, against head-to-head trials versus liraglutide in patients with obesity and in patients with pre-diabetes and patients with osteoarthritis. And we have total number of participants that is 26,000, and all are multiple phase 3 trials. And approximately 8 million people in the world are using Semaglutide in one form or the other. And we know Semaglutide has a brand, and then Semaglutide has cheaper options, and we'll discuss the cheaper options as well. We will discuss only 3 trials. Once weekly Semaglutide in adults with overweight or obesity. And then the endpoint was the percentage of weight loss and responders. This trial was in place to compare the effect of Semaglutide versus placebo on multiple risk factors, on multiple obesity-related complications, which are the cardiovascular events or the common anomalies or glucose metabolism. The endpoint was greater than 20% weight loss was achieved. Every third patient had achieved a weight loss of greater than 20%. The effect of continued weekly subcutaneous semaglutide versus placebo on weight loss. Now this becomes a very important question sometimes. When patients come, they ask कि चले हम weight loss का drug शुरू तो कर देते हैं, लेकिन ये दवाई कितनी देर के लिए खानी है? तो the trials suggest कि once you start it, तो it should be there for a very long period of time. ऐसे लोग जो discontinue कर देते हैं Wegovy को, उनके साथ फिर ये होता है आखिर में this. Ultimately जो प्लेसिबो पे चले जाते हैं, जो कोई ड्रग्स नहीं ले रहे, दे गेन वेट, अ रिडक्शन ऑफ 10.6%. फॉर दोज हु आर कंटिन्यूइंग Wegovy, उनमें एडिशनल वेट लॉस होगा. फॉर दोज हु हैव लेफ्ट Wegovy, उनके अंदर एक 6.9% का वेट गेन होगा. अच्छा, एक स्लाइड मिसिंग है यहाँ पे. चलें. For osteoarthritis patients, again, an estimated treatment difference of 34 percentage points. And we're living in that part of the world where females fail to achieve a peak bone mineral density. We don't have female athletes here. We don't have regular people who go to the gym or do exercise. So here osteoarthritis becomes such a key factor. Using semaglutide or Wegovy alone for this, helps us reducing the osteoarthritis by 34 percentage points. Now, a scenario that we wanted to discuss, a female of 41 years with a BMI of 35 and an HbA1c of 6.2, who is a known hypertensive, has a strong family history of type 2 diabetes. Lifestyle interventions have failed repeatedly. She asked the doctor, my sugar isn't diabetes yet, should I just wait? Any answers? What should be the treatment modality for this patient? Pre-diabetic patient है, अभी उसको diabetes नहीं हुई है, at an HbA1c of 6.2 but a BMI of 35. Should she be initiated on some treatment, or should she just wait for diabetes to happen and then the treatment could start? Could there be anything that could reverse her diabetes at this point in time? There is a concept of diabetes reversibility. So is that possible? Anyone? हमारे पास एक और माइक भी था. एनीवन जी? So if it is the reversibility of diabetes, achieving normoglycemia, then it has to be semaglutide. It has to be a GLP-1 agonist. And this is the talk of the town, and this has been the talk of the town for so many years. Okay, could diabetes be reversed? Could pre-diabetics reverse completely? The answer is that with the appropriate drugs, somehow yes. Normoglycemia is what they define as an HbA1c of less than 6 or a fasting blood glucose of less than 5.5 millimoles per liter. So we've established now on the basis of a trial that continued for 52 weeks that normoglycemia was achieved in 81% of the population that underwent this trial, as compared to placebo, जिन लोगों ने अपनी डाइट को कंट्रोल किया, कोई ड्रग यूज नहीं किया, अच्छी एक्सरसाइज की, जब उनको कंपेयर किया गया अगेंस्ट अ ड्रग, अ GLP-1 एगोनिस्ट, तो 81% लोग ऐसे थे जिन्होंने नॉर्मोग्लाइसीमिया अचीव किया. This is the SELECT trial, a very large randomized control trial in 804 sites. And look at that number, the participants. It's 17,604 participants. The primary endpoints of the trial is that semaglutide reduces MACE, the myocardial atherosclerotic cardiovascular events. It reduces them with all three components, the cardiovascular death, non-fatal MI, and non-fatal stroke contribute to the MACE reduction. The effect of semaglutide on MACE appears to be consistent across different population groups. So whether it be Asian population or European or American population, the effects remain the same. Semaglutide reduces the risk of death from cardiovascular events by 15%, and semaglutide reduces reduces the risk of heart failure by about 18%. Another trial, the ESSENCE trial, demonstrated the benefits in metabolic associated liver disease, MASH, an improvement in liver fibrosis as well as cardiometabolic risk factors in patients with non-cirrhotic MASH. The results were It improves both liver fibrosis and MASH resolution. It improves the non-invasive biomarkers of liver fibrosis and MASH disease. And it also improves and is consistent that the observed effects in trials and other diseases, all parameters related to cardiometabolic disease are also affected. So the proportion of patients with improved fibrosis is about 37%, and the proportion of patients with improved MASH is about 62.9%. Okay, another scenario is BMI of 37 in a 47-year-old female. She reduces treatment after watching social media videos claiming these injections make people lose muscle and become weak. Sarcopenia is something that we fear sometimes when we are addressing weight loss in such quantity. So, what would be the treatment in this patient? Anyone? एक सवाल था जब हमने डिस्कस किया था कि हम ये प्रेजेंटेशन करेंगे सार्कोपीनिया से रिलेटेड. वी हैव द आंसर फॉर दिस. इट्स द सिमिलियन ट्रायल. सिमिलियन ट्रायल में ग्रेड 3 ओबेसिटी के लोग थे विद वन कोमॉर्बिडिटी एंड बीएमआई उनका 40 था. द रिजल्ट ऑफ दिस ट्रायल इज इंटरेस्टिंग एंड दैट शुड बी read out. Semaglutide 2.4 milligram by the name of Wegovy produces robust weight loss, achieving 10% at 7 months and 13% at 12 months. The muscle function improved despite weight loss, with significant gains in hand grip strength and reduced prevalence of sarcopenic obesity. Overall, semaglutide improved body composition quality, emphasizing fat loss, muscle function preservation, and metabolic health, not weight loss alone. The Similian trial emphasized that loss of lean mass is expected to occur alongside weight loss as a mechanism of normalizing body function, but 84% of the weight loss with semaglutide was from adipose tissue, with no statistically significant difference in lean tissue or muscle volume observed between semaglutide and placebo groups. So this trial answered the question of sarcopenia as well. The last scenario is a female with a BMI of 34. She is highly motivated and eligible for treatment. During history taking, she mentions her sister had medullary thyroid carcinoma. So she's watched videos and reels about weight loss, and she's very enthusiastic about starting semaglutide by the name of Wegovy. She has a family history of medullary thyroid carcinoma. Do we start her on Wegovy or semaglutide? So the answer is yes. And my answer will be a little different, because there are a few contraindications, and this was what we tried to mention, that even if she was highly motivated and we have a drug and we could just contribute to her weight loss, the problem with this patient is that she has a family history of medullary thyroid carcinoma, which is an absolute contraindication to the start of Wegovy. Apart from this contraindication, we have a few other contraindications as well. A patient, whether she's had medullary thyroid carcinoma herself or she has a family history of MTC, she'll not start Wegovy. If she has had a history of pancreatitis, again, Wegovy is not the drug for her. Wegovy is also contraindicated in pregnancy and breastfeeding. A 49-year-old male with 37 kgs, OSA and pre-diabetes. Someone asked if a cheaper drug or another very rapidly used drug produces the same effects, why would we use semaglutide? We have a newer drug in the market that by the name of tirzepatide. Why would we use semaglutide instead of tirzepatide? So the answer for this is just one slide, this one. So it's not only weight loss, it's the quality weight loss. Trials have shown that we can achieve transformative weight loss with Wegovy, that is only 21%, tirzepatide 22.5%, but the other outcomes remain unanswered. The cardiovascular events, there is no single trial that shows that tirzepatide has any benefit. For Wegovy, we have a trial, the STEP trial, that shows that 20 to 26% patients will have benefit. Then STEP teens, the kidney outcomes, the liver benefit, and all-cause mortality, these are all ongoing trials, and there is no published data as such as yet. They might publish it in a few years or in a few months, but for now, this is the safest option. And when it comes to heart failure outcomes, Wegovy जो है just supersedes or leads tirzepatide by this almost half percentage. 38 and 76 will be half. 69% of the patients will have benefit with Wegovy as compared to 38% of the patients which will have benefit from heart failure outcomes. In January 2026, there was another recent data. I think this is the slide that we've just discussed. The biosimilars, we have cheaper options of semaglutide. We have a drug that comes, it has a monthly cost of about 3,400 and 3,600. ये lowest तो मैंने यही सुना है. And yesterday they were coming to me and they told कि जी अब हमने मज़ीद reduce कर दिए. So why would we use some drug that is more than 20,000 in cost per month, and why would we not use a drug that is 3,000-4,000 only? The problem is कि Ozempic या Wegovy original biologic है. Original biologic will undergo many trials, the non-clinical, clinical and then clinical phase studies. That is what makes it very safe. जो biosimilars हैं, they will not go all clinical trials and उनके end पे सिर्फ comparative clinical studies हैं. They make a reference कि since semaglutide has this effect, तो हमारी भी semaglutide है तो it will have that effect. कोई trials इनके नहीं है. और फिर कुछ generics हैं जो सिर्फ bio equivalence की उसके ऊपर market में launch हुई है. तो beware, immunogenicity is one concept कि against many impurities your body will react, will respond, will develop antibodies, and those antibodies in the near future can cause many harmful effects. A major concern with immunogenicity are the antibodies directed against the biological medicine. Immunogenicity can only be assessed via clinical safety data in the relevant patient populations. Now, if you look at this, the initial data is the same for Wegovy and for other biosimilars. But have a look at this. These are the impurities, and this is the reaction of the body to those impurities, and it peaks at a later stage. So, living in a world where we fear carcinogenesis, we fear impurities, and we fear so many other factors, immunogenicity could be a very credible evidence against biosimilars and generics that are cheaper in price, that may affect weight loss, but then in the long run, they might have side effects as well. Apart from immunogenicity, biosimilars will have pharmacological unpredictability. They may have genotoxic or mutagenic risks, and they may have toxicity from residual chemicals as well. With that, we come to the end of the slide. If there are any questions, so we can have them. After that, Ihtisham will come with us for a couple of minutes, and he'll tell you about the cost comparison and of Wegovy. Any questions? Most of the questions I think that we had in the ward were answered in the scenarios we made it as such. Any questions? A mic then out the way. Most of the times it's the targeted weight loss, right? कि अगर किसी का BMI जो है हमने 23 के अंदर लेके आना है तो it might be 30 or 40 kgs. The question was कि अगर हमने अचीव कर लिया है तो उसके बाद हम ड्रग को बंद कैसे करेंगे? The problem with these drugs once you initiate it, इसलिए आपकी पेशेंट की काउंसलिंग बड़ी ज़रूरी है कि आप इसको जल्दी से बंद नहीं कर सकते. You have to make a plan कि आपने कुछ अरसे तक जो है वो उसको यूज़ करते रहना है, और ये कुछ अरसा सालों में है, महीनों में नहीं है. तो वो डाटा वो शो कर रहा था कि लोग दोबारा से वेट गेन करना शुरू कर देते हैं. माई प्रैक्टिस इज, एंड दिस इज अ प्रैक्टिस ऑफ मोस्ट पीपल, कि अगर वंस वीकली डोज है तो जब हम बंद करेंगे तो उसको आप वंस वीकली ना करें, वंस फोर्टनाइटली कर लें. आप महीने में एक दफ़ा लगा लें, लेकिन आप उसको डिसकंटिन्यू ना करें. जब आप डिसकंटिन्यू करेंगे तो लोगों पे जो एक इफेक्ट आएगा वो सप्रेशन का, वो एकदम से खत्म हो जाएगा. तो इसलिए वो जो इंटरमिटेंट डोजिंग हम करना शुरू कर देते हैं, दैट इज द आंसर टू दिस प्रॉब्लम. सो व्हेनेवर इफ इट इज Wegovy, इफ इट इज Semaglutide और एनी अदर ड्रग, इनमें हम स्पेसिंग को बढ़ा सकते हैं. इनमें हम डिसकंटिन्यू फॉरन करेंगे तो वो एक रैपिड वेट गेन जो है वो अचीव कर लेंगे. So this is what we do. If it is once weekly Wegovy, we use it every fortnight. वी यूज इट एटलीस्ट वंस अ मंथ, बंद नहीं करते हैं उसको। वो इफेक्ट ऐसे ही आता है, 3 हफ्ते स्किप किया, 1 हफ्ता लगा लिया, तो किसी ना किसी तरह वो अपना जो वेट लॉस है उसको मेंटेन कर लेते हैं। एनीथिंग एल्स? अच्छा, वो थोड़ा सा हमने आंसर किया वो उस पेशेंट का जो बहुत ज़्यादा खाना खा के और उसके साइड इफेक्ट्स आना शुरू हो गए थे। येस, वी डू इट ऑन फार्माकोलॉजिकल थेरेपी, हम ऑनसेट और प्रेवेनेट और सब कुछ ही दे रहे होते हैं, लेकिन जो स्टेप अप थेरेपी का कॉन्सेप्ट है ये यही है कि आप 0.25 से शुरू करते हैं एंड द पेशेंट कम्स बैक टू यू एंड ही सेज कि कोई एफिशिएंट वेट लॉस उसको नहीं हुआ पहले महीने में, कोई बात नहीं, 0.5 पे जाएंगे, आहिस्ता आहिस्ता वो थोड़ा सा एक्लेमेटाइज करेगा, फिर हम 1 पे जाएंगे, फिर 1.7 और फिर 2.4 पे। दिस इज द स्ट्रैटेजी दैट वी अचीव कि यहाँ पे जो जीआई साइड इफेक्ट्स हैं, जो नॉजिया और वॉमिटिंग रिलेटेड कॉम्प्लिकेशंस हैं, वो कम से कम हो जाती है। बट देयर इज नो कॉन्सेप्ट ऑफ लीविंग द ड्रग। हम उसकी डोज को स्किप करा सकते हैं, हम उसको स्टेप अप करा सकते हैं, एंड समटाइम्स पीपल चेंज फ्रॉम tirzepatide टू semaglutide या वहां से वहां पे, तो वहां पे भी हम यही करते हैं कि लोएस्ट पॉसिबल डोज से हम शुरू करके तो आगे तक लेके जाते हैं। ये स्ट्रैटेजी जो है इज द मोस्ट इफेक्टिव स्ट्रैटेजी नॉजिया और वॉमिटिंग को मतलब ट्रीट करने के लिए। बस ही ले जी इंतजाम जी शहजाद। Thank you Shahzad for the information and yes he was very precisely this was a civilian trial और उसके अंदर यही है कि मसल मास जो है वो नहीं रिड्यूस होता and this was another useful information that he gave. Anything else, anything that anyone else would want to say? अच्छा, जो इसकी प्राइस है उससे रिलेटेड एहतशाम में सिर्फ 2 मिनट की बात करनी है। एहतशाम प्लीज।